This
Yeah, they're
patient is
way-
about 45 years old. He have very deep bite, and you can see from the teeth severe attrition. Already, the pulp of chambers will be opened. Why? Because he is grinding very strongly, and even you can see the four central incisors all is distracted. So the only way to reconstruct this case is to raise the bite because his facial height is come down now
Yes.
about 3 millimeter or 4 millimeter. He lost the height, facial height. So only way to raise the bite is one of this jaw should be all grinded and raised about 1 millimeter, if 2 millimeter. So what happened that we grinded all these and this four which is damaged, we kept the posteriors and we raised about 3 millimeter and we did for him a full crown for the upper and the four central. This one we did it because it's need crown. It's all a big feeling. Okay, so this is the case after preparation. This morning I did it because you can see it. So this is the 40s prepared.
This is
No need for grind from the occlusion because it is already we are raising the pulp, and we didn't do any endo work for him because only minor preparation. So so if what will happen, the laboratory will raise the bite like this, and we did for him 1, 2, 3 crown, 1, 2, 3, 4, 5, 6 together, and 1, 2, 3. And by this crown we closed all the spaces that he has having in the old time. See, there is spaces here. He was having spaces. So I will show you now in the
Doctor, you fix it by bridges.
by bridge, yes, but not three
Yeah,
units
yeah.
up and four together. Yeah. So now I didn't cement it totally because usually when you raise the bite, it looks like somebody who used to walk without talent, the shoes. Now he started walking, he will have
Normal.
a TMG pain maybe. I can't because all this muscle, muscle nerve disharmony, disbalance, he cannot walk.
Reaction.
Yes, he told me I am feeling not comfortable. It's normal. So usually when we raise a bite, we have to start with prosthesis or temporary crowns made by resin, soft. Then we go to the ceramic. But immediately I did ceramic for him, but I didn't fix it. I am waiting about 1 week to 2 weeks and see if he have temporomandibular joint pains. Then I have to reduce little. But his height now is within normal limit. If he don't have any pain, within 2 weeks I will fix the cement totally. Okay. So let me show you the last X-rays. Do you see the case finished? I cemented totally the lower, but the upper no. Yeah. This is his smile. Okay. Can you see the smile?
yeah.
When you do a smile for any patient, when he laugh, the third lower should be seen. And the line should be parallel to the lip, not like this, not like this. The midline should be in the middle. This is very aesthetic when you are working. It's very important because when you are talking to any patient or to any person, immediately your vision will come to the teeth, the first. So you should be careful during your clinical work, all right? So this is the smile, you should keep it. 1/3 of the teeth should be, and you ask always your laboratory to do 3 shades, enamel, dentine, and gradually going to the dark color up, okay? So this, see now, this is the teeth. It's become little more bigger because in the childhood he had spaces between the teeth. We tried to close it. This is the reason the teeth become bigger than the usual. He accepted this case, okay?
It's holding smile.
See,
Ah, so white.
By the color.
he want upper to be white.
Ah, yes.
The lower we did it the same if you see. Look.
Uh-huh.
See the lower, we changed the color. But the upper he wanted.
So different, like
Yes, but he smoked too much, and I think within. He wanted this color. I see. It's. I wanted to be more darker, the lower, but he said no. Let it like that. Okay. So it's very important also when you do preparation, you go half millimeter below the gum. Why? Because after 7 years or 10 years, this gum recession will happen, and then the borders will be visible. When he smiles, it is not nice. So always when you do preparation, try to go little down, about half millimeter below the gum. Okay, and let your laboratory also to go to the line of preparation. It's also
So it will stay the same position?
it's very important. Sorry. See the lines is okay. You can see the smokers always the gum color. It is dark also because the nicotine, the nicotine. You see.
it's not for you.
Okay.
You do postage for everything.
Sorry.
I have a postage for everything.
Yes. Crown, bridge. The
Yes.
6 together, and 3 here and 3 here.
For upper and lower? Or
No,
only
no,
upper?
the lower only the 4. See, this is the upper. You can see there is spaces between the teeth. I tried to close this space, but once you close the space, the canine will become more bigger.
Yeah.
You see? See the teeth how it is damaged,
smaller
smashed.
than- yeah.
But now with this crown, we will stop this grinding. We'll stop the recession. If I leave it 2 years more, there will be no teeth. It will reach here. Now, before it was here, the teeth, you see. Now, with biting, all this teeth is damaged. Little more, the pulp will be exposed from inside. You see?
And in this situation, the patient feel any pain
No.
or no?
No, he
Nothing.
feel that it's
Just
not healthy. But if after 2 years he will start feeling pain because all this pulp will be exposed, because he's smashing, it's opening, it's going fast.
So the bite will
You-
be different, yeah?
Now the bite is different. We put porcelain. I raise the face. His face height become normal. You know when the bite is deep and too much close, this line, smile line on the face, come like somebody looks old.
Yeah.
But when you raise the bite, these lines will become normal. Okay? This in prosthesis, when you are going to take lectures, you do always measure. You ask the patient to do spell number M. Once you do word M, so you measure the height from a point here and a point here. And when you ask to close in center relation, it should be only 1 to 2 millimeter difference. This is the normal height of the face. But if it is 4 or 5 millimeter, then you have to raise the bite. Okay, you will take it in prosthesis, in total prosthesis especially. Okay, and in crown and bridge here, I use it, and he was fantastic. 1 to 2 millimeter, ideal occlusion we have. Okay, let's now. Sorry, in this place we don't have sit down. If you want.
Can I use this?
Sure. Look, let me tell you something. Tomorrow I am leaving Yerevan to 1 week. I will be back next Tuesday.
Okay.
But I will reach in 2 o'clock. So our lesson will be in the not next after in Monday. We will start seriously, and I will try to give you recompensate the times. Look, what I have to teach you in these sessions, please, during my absence, I want all of you to prepare the maxilla, the jaw, upper jaw, the lower jaw, the mandible, okay? Please, you go through YouTube, through Google, all the same. I want you to study the bone, the nerves, blood vessels, the muscles, please, and all these muscles from where it is innervated. This is the key of your success in your life. Okay? If you don't know anatomy, don't do a dentistry. I am telling you. Because if you have a problem during injection tomorrow or something like that, you have to know where you are going to give anesthesia, which nerve you are going to anesthetize. If hematoma happened during your working, this hematoma from where it is came. You understand? From which vein, from which artery. You have to know the source of this hematoma. Everybody can be a dentist, but not everybody can solve the problem during your work. So the difference between success dentist and non-success is to manage the problems. All right? So today, do you want me to continue last time what I talked on general about maxillofacial, or shall we go to anatomy, please?
Go to anatomy.
Okay, we'll go to anatomy, and so
You want him to repeat something from the first?
so let's start.
Sorry, you can't repeat from the first.
Okay, we'll talk. Look. Today I will talk on general.
Okay.
I will speak fast, but
Because there is substitute in there.
okay. We'll speak. Look, I will start today talking about the mandible, the jaw. Okay, the lower jaw, and you somebody have to take. This is the you can go the slideshow. You ask Google and you go this one. Or your exam and lectures will be through what I am giving you. Okay, I am choosing for you lectures which is important for you in your life. So let's start by the mandible. What is this lecture is containing? The osteology, the bone, the attachment and the relation to the mandible, the blood supply, the lymphatic drainage. You know, if somebody come with dental infection and he will tell you, I am feeling some swelling here or something like that. You have to know this swelling is coming from which tooth. Because the molars will give swelling in this area. The central incisors will give lymph node which is submental. Okay? The gum infection will give. The tooth infection will not give you lymph node infection. Okay? Always, usually, there is some soft tissue infection which will go to the lymph nodes. We'll talk about it. The age changes, you know, somebody if is young, his jaw, the child jaw is something, the middle age is something, and who is under 80 or 90 years, you will see the difference of the jaw because bone resorption will happen and the changing of the bone we are going to see. The applied anatomy and the references, okay? So, the mandible, it's a Latin come from a Latin mandibular jawbone. You read all this. I will give you only the important things. What is the mandible? This is the part, is a very strong part of the jaw, the face. This is the lower part, the lowest part, and the most stronger bone after the clavicle. The clavicle is the strongest bone in the body, and the jaw is the next strongest bone in the body. So what it is consist? Look, this is the body. All this part we call the body. And this is called the ramus. Okay? The upper is going up is called the ramus. This is called the condyle. The condyle is this is the condyle process, is the area which is moving. All right, it's like the knee.
Yeah, like bone.
Okay, it's bone moving, and this is the part in the head you will see is called glenoid fossa. The glenoid fossa and the condyle, there is something is called the disc or the cartilage. Like the chicken, if you are checking his leg, you can find a gelatin. So what happened when this condyle is moving? This gelatin, what is called the disc, is moving together. And once we are closing, it's coming back because the ligaments is taking the disc back. So the jaw, when it is closed to the teeth, again the disc will come to the place. Sometimes what is happening that if the jaw is opening and the disc coming anteriorly, we ask the patient to close. Once he closes, the disc will remain anteriorly, will not go back. Then he will tell you click. You will hear clicking voice. This clicking voice because the disc didn't return back simultaneously with closing the mouse. All right. So this clicking is not dangerous as much as if it is associated with pain. So clicking with pain, we have to treat the patient. We are going to talk about it. But clicking without pain, it's not much important for us. All right. So this is we are eating. We hear voices from
Yes.
here. This is the clicking because the cartilage is not functioning normally here. And why this is happening? It is happening because some patient they don't have enough teeth or extracted teeth, or he have badly breach. Then look, if you are walking on a street and you are one of your talent is long and one without talent, so you will start working in imbalance. Same in the mouse when you are going to fabricate a bridge. You ask the patient to close. Once he close, he have to close. He have to stop on the land strongly, not one up and one down, because if he don't bite normally, then he will start having temporomandibular joint pain because the muscles are not functioning. The balance of the muscles is not normal. So it is very important. Let me tell you something. I read one time in a journal that one patient suffered 18 years of headache. 18 years, she did MRI, CT scan, and everything, took many medicine. And one time she went to the dentist and he asked to bite on a paper, articulating paper, and he found a high point. He just grinded slightly and the patient relieved 18 years of pain, suffering, and too much money paid for it. And she wrote in a medical dental journal that every dentist, when he do his work, do it perfectly. Don't miss a small high point. See, she suffered 18 years. So please be precise in your work and everything. All right?
Sorry, one question. If someone has grinding,
Sorry?
if someone has grinding of the teeth,
Bleeding.
no grinding,
Green.
smell,
Clinking?
no
Grinding
grinding,
like this.
Sorry, say in Arabic if you know. No.
Grinding.
Grinding,
Yeah,
grinding.
grinding,
Ah.
yes.
In
It
the night.
causes the TMG to
That's
move,
right.
and
Thi-
also
this-
the back pain.
Exactly.
And what about dislocation of TMG?
We will talk about it also. See, if somebody are grinding his teeth, this is the disease of this century because all we are living in stress life. About 30% of the girls and
Yeah.
20 to 25 boys. Now I am sure it is raised more, especially the student during the exam. They will have these problems because the stress of the life is causing that we are grinding in the night without feeling. So once you grind strongly on your teeth, as this case, what happened, he smashed all his teeth. When you are grinding, a muscle spasm is happening. The muscle is retraction of the muscles. Muscle spasm is happening and it's causing this temporomandibular joint dysfunction syndrome is called.
Even when you cut something also.
Yeah. So to treat this case, actually, it's need many specialists. He need psychiatric. He need. It's our responsibility. All right. Need dentist, orthodontist. So you have to know what is the cause of it. If it's psychology, then we have to refer to psychology. If it is because of, as I told you, a high point or something, or sometimes we do teeth occlusion adjustment. You are going to take it in your study. You put a carbon bite and the patient will bite. And you will check because the jaw is moving like this movement. Any high point, you have to grind it. So once he close, there should be all normally. In the same time, you have to put your legs. Not one touch here and after touch here. Look, if you are having two shoes, one high, one down. So what happened? Your your skeleton here will not function normally. You will walk like this, then you will have a pain.
Yeah.
Same the joint. If the occlusion is not stable, then you will have this joint pain. If a patient remove 2-3 teeth, then you have to replace it either by implant or bridge. You have to restore all his teeth. His occlusion should be perfect, then this pain will disappear. As much there is a problem in missing teeth or orthodontic problem, teeth touching before others, he will always suffer this. And if having family problem or suffering from stress or something like that, should be also the psychologist should participate in. So it is 2-3 specialists have to work to control this problem. Orthodontist, psychologist, restorative dentistry, all this have to work together to give this to solve this problem. So let's continue. As I told you, this is the condyle, which articulation. This is called the coronoid process. This coronoid process, you will see now muscles of attachment will be here. The temporalis muscle will attach here. It's the one responsible for opening and closing the mouth. Okay. If we come, this area is called submandibular fossa. Yes, this fossa that we have the submandibular gland, which come through Wharton canal and open just below the tongue. Sometimes when we are speaking, we see saliva come out from the mouth, because just behind the tongue we have 2 orifices which come saliva, and this saliva is coming through this submandibular gland and open. The canal is called Wharton canal, and just in front of this here area we have 2 orifices. The right and the left side is the saliva opening here. The submandibular gland is the biggest gland, one of the biggest gland in the oral cavity. Once we arrive to gland, we'll speak about it. This is the submandibular fossa, and we have some sublingual fossa. This line, this here is submandibular. Here is sublingual fossa. Also, we have sublingual gland, which is opened. We have many opening in this submandibular gland. We don't have only one canal. Okay, we have several canals. Okay, but the much one is causing problem for us is the submandibular gland, because sometimes we have stone inside. Stone. Stones, yes. Stones, salivary
yes.
stone, which is inside and it's blocked the canal. And what will happen? Swelling in this area. The patient will start having pain. If the infection will continue, this gland will return to fibrotic. They will lose the function. It will not function more. All right. So this you are going to take in salivary gland diseases. You are going to study. But as much I am speaking about now, I am giving in advance cases. We come to the mandible. Let's continue. We have the very important structure for us to give anesthesia. We have 2 foramens which is very important in the mandible. One is called mental foramen, and one is called the mandibular foramen. This one, the inferior alveolar nerve, which is coming, the trigeminal nerve, coming inside and giving innervation for all the teeth, and it is coming out from the mental foramen. All right. This is very important for us to give anesthesia for the patient. So the teeth are inserted. We have 8 teeth each side, 3 molars, 2 premolars, 1 canine, and 2 incisive. Yes, incisors. So they are all inserted in the alveolar bone. This is the alveolar bone. It is a strong bone, and this area is called symphysis, the chin. Okay, or they are saying here mental protuberance, because it's protuberance, something which is coming out. All right, tuberosity we say for it, and this is the alveolar bone. Okay, let's go for the other side. Let's talk about osteology. So as I told you, it is the second bone after the clavicle bone in ossifying in body.
The body.
Yes. You read please all this one. I will speak only the important things for you. This is the ossification, how it start. Usually in the 6 weeks after pregnancy, the jaw, lower jaw start functioning. It start in this area after the nerves. After, you read it please, and you will see. The endochondral ossification is the cartilage. The cartilage also you read it. The coronary process, the mental region, how it is starting, and ossification start by the 7th month in life. This is eternity. Yes, you read it, please. So let's again come here. The lines. Yes, you have here the body, the inferior body, the angle. This is the anterior region also. This is anterior region is important us to give regional anesthesia. Your finger will come always touch the lowest area in the anterior region, and the needle should go parallel when you are giving anesthesia. So this area is important to choose the lowest area, because the nerve is passing through there. This is the oblique line, is important also because we have muscle attachment in this area. The masseter.
Sorry, doctor.
Master.
If the needle touch the nerve,
Yes.
the patient lose some ability, or it will be recovery.
Look, if it is damaged, look, any nerve, it is cut, the patient will lose sensation. It is damaged, maybe 1-2 months, he will feel some electric shocks, which is a healing process that we call paresthesia for it. Okay, paresthesia, that the sensation go and come. It's like that. So it is very important when we are giving anesthesia, you put your finger here, and the other one, the needle will come parallel to this one. So once the needle go from other side, you will touch the bone here. You touch the bone, take it 1-2 millimeter, and you inject. Okay? Then the nerve which is coming, the inferior alveolar nerve inside, it will be anesthetized. Don't inject once you touch the bone. Don't inject here, because you will injure the blood vessels. Because what is the nerve? The nerve is the blood vessel. It's artery, nerve, and vein.
Yes.
If you inject inside, hematoma will happen. So once you touch the bone, if you take it 1 millimeter, 2 millimeter back, you are in safe area. You take the needle out and see if there is a blood. That means you are in the blood vessels. Don't inject. Again, take it out and do again and inject. Okay, this is the way of doing the injection. Once we speak about sedation, we'll talk about it. So this is the head, and this is the neck. The neck is very important in fractures, especially with children. Any child come to your clinic and you will see too much tomorrow. Children who fallen over some table or something like that, you will find a wound here. Wound, جرح. You send him for X-ray, panorama. You will see a fracture happen in this area. The neck is a growing center in the mandible in the children, which stop usually at the age between 12 to 14 years. After 14, it will stop.
The mandible?
Yes, the mandible stop growing. So the growing center in the jaw is this neck area in the children. Okay? So it's very important, if a child fall down in the small age, you have to observe him and you send him to oral surgeon, because there is some training we do it for the child to increase the growing area in this area. Because what will happen if this one is fractured, then growing will stop. So what will happen? This area will grow and this area will not grow. What will happen? Bird face, we say. His jaw will be small and the upper jaw is grown. So this is called bird face. Yeah, just a minute, sorry. Ayo?
على أجر أوي نين اللي
ايوه ليلتنا ايوه ها ha
شو قبته أمي
okej ja vlit ուրեմն նայեցեք ինչպես կուզեք ես միակ վաղը վիճամփորտ եմ եկող 3 շաբթի ասված ուզեմ այստեղ գլինի Գեսորեն վեր ջամը 2-ին հոս կլինամ այո ասված ուզեմ եղավ լիլիթ եղավ բարի բայ բայ So, so from here go, and this is the what is called the mylohyoid line, which is inserted the mylohyoid muscle. The mylohyoid is also responsible to open and close the mouth. Okay, the angle is also important because we have the root traffic accident when it is come. We have too much patient come the angle fracture. Once a fracture happen here, we have two kind of fractures. A fracture which is called favorable fracture and unfavorable fracture. Why this it is happen? It's depend. If the fracture line is like this, okay, so the muscle insertion of the masseter will take the jaw and keep the bone in place. But in case of unfavorable fracture, the muscle traction will be opposite one to each other and will take the jaw to other side. Then we have to open and put a plate or whatever be to put the bone in place. This is the angle. So the first fractures we have usually is the condyle fracture and the angle fracture, the body fracture, the symphysis fracture, and it's very rare. It's common but not much rare. There is the coronoid process which is fractured here. Usually in coronoid fractures we don't do much things. The most important in children we have to treat this one by using muscle traction. This is in oral surgery. Okay. Let's go to other. The body. It consists outer and inner side. So this is the angle, this is the oblique line, usually this mental foramen will be between the first and the second premolar, and this sometimes the most will be second premolar below it. You see, it's in the middle. Usually it give innervation, not usually, it's give innervation to the lower limb. Sensation, not motor. It's not responsible for moving. Sensory nerve. All right. So this is the alveolar bone, which is supporting the alveolar bone, and what is this mental? This is called mental protuberance. Mental protuberance. It's a bone, little more bone. Okay. See, this is the bone without teeth, the mandible of infant, before the teeth come up. Okay, see once the teeth is erupted, how it is changing. Without teeth, see how it is. And the old people is the same appearance. Okay. This is also the body, and you can see myloid line, submandibular fossa. Also, you read it all. This is the digastric fossa. The digastric fossa is the muscles which is inserted by the mylohyoid. We have hyoid bone. Sorry, we have hyoid bone here. If you swallow, you will feel everybody. There is hyoid bone here. This mylo bone is attached with here, and it's moving the tongue up and down. It's responsible for swallowing and opening and closing the mouth. This is the digastric fossa, which is the muscle of digastric. We have digastric, lower digastric and upper digastric muscle insertion. Yes, you will see. The remus, the borders, the process. Okay. This is the muscle. We have a masseter muscle which comes from the zygomatic arch here and come down to the angle. It's the one responsible. This is the muscle. Yes, masticator. Eating, okay? And we have another muscle which is the buccinator, which is also coming here. And we have also 3-4 muscles in this area, platysma, and you learn. This is small muscles, all responsible also for smiling, moving. This movement, they are the one. Auricular, you learn all these ones, okay? This is the muscles from inside. We have the myloid muscles, which is coming to the hyaloid bone here, and is the one responsible for moving the tongue, swallowing, opening, closing. And this is the temporalis muscle, which come from here. All this muscle go below this zygomatic arch and insert on this coronoid process, is the one responsible for closing and opening the mouth. We have the lateral pterygoid muscle, which is also responsible for opening and closing the mouth. It is inserted in the internal side of the condyle. We have another, this is lateral. This is internal pterygoid muscle, which is also responsible for closing the mouth. Okay, this is the area of attached to the bone. The blood supply and nerve supply, and the lymphatic drainage, please, you read it about it all. This is without teeth, the jaw, you can see. This is for the children. The children have only 10 teeth.
Yes.
All right? They don't have premolars. This first molar, second molars, and below we have the first premolar and the second premolar, which are this usually in 9 years old. This premolar, first premolars for the children erupt, and the second premolar erupt in the 10 years old, minus plus, okay? And
About 4 millimeter.
yes, all right. In adults, okay. So see the adults. What happened? The two molars in children replaced by first premolar, second premolar. In adults, this one is erupt in 6 years old, and 12 years old, and 18 years old. First molar, second molar, third molar. Okay. The canine usually is erupt between 12 to 13. The incisors, lower incisors, start erupting 6, 7, 11, 10, 11, 12. The canine 9, 10, okay, 6, 12, 18. This is the reason we say ضرس العقل يعني wisdom tooth, because it's not related to the wisdom tooth, but usually somebody will become wisdom in the age of 18. This is the reason we say wisdom teeth.
Doctor,
This is the foramen, sorry.
until now I don't have wisdom teeth. I'm
It's
a
very
22.
no. It's if somebody. It's very common now. It's very common. If you are not, you are. You should be
Maybe
happy.
it's normal. Come.
Why?
You should be happy if you don't have, because now what happened? Look, if you look in the old age, which is discovered the skulls below the lands or something like that, you will feel there is no caries, there is no all the teeth normal,
Yes.
no missing teeth, nothing. Why? Because in the old time, the people used to eat everything, the meat which is not cooked. There was no pasta, there was no pizza, things like that. So all the teeth is needed because he is grinding. He wanted to use these teeth. But now with these children, all the chocolates and things like that, soft food, the teeth becoming missing with the time.
Yes.
So the oral surgeon, they have too much work, because once the wisdom tooth becoming to erupt, there is no place for it. It's keeping burned. I think if the life will continue like that, maybe we don't see it. But too much children will born and there is no teeth in the mouth. It's all in the bone, you see, because they are not using it too much. We are finding too much now impacted teeth in the bone, because they are not using it. Everything soft,
It's
everything, you see.
pretty.
Yeah. See, in the old age, if you extract all the teeth, what will happen? Bone resorption. See before how it was, the height and everything.
Sorry,
More-
doctor.
And after removing the teeth, every year the patient will lose. Every year the patient will
Sorry,
lose
doctor. What's the benefit of the wisdom teeth?
the.
Venom.
if all the jaw is okay, it's a normal tooth. You can do and eat and everything. Okay, because if the patient have big jaw and the size of the teeth is normal, then it will come normal. But what happening that the size of the teeth becoming more bigger than the jaw. This is the reason we are referring to the orthodontist. He is doing cephalometric study and measuring the size of the jaw and the size of the teeth. If the size of the teeth is more than the space, then he is advising us to remove either the first premolar or remove the wisdom tooth to keep space, you see. But if we see that it is impacted and causing pain and things like that, then we have to extract the
So
wisdom
we
tooth.
need a rest.
So just a minute, we'll stop. Why, you want to smoke, yes?
No, smoke. My friend is smoking.
Easy smoke nargila.
Oh la la,
All
man.
I did is so good.
One nargila, you know, I did research on cigarettes.
Yeah.
One nargila is 2-3 packets, you know.
Yeah,
So
but it is
it's very dangerous.
You don't understand maybe now.
Yeah, really.
Don't hear.
He will not know now. Later he will know. I was having, I did research on 530 patients, oral cancer, smokers. I worked in an area which was not allowed for the lady to smoke. So what they are doing, the ladies, they are using smokeless tobacco, which they chew it by putting in the
Oh
oral
my
cavity,